Everyone. I'm Mark Cartoski from Nemours Children's Health, previously AI DuPont Hospital for Children. I'm the director of cardiac MRI there, and then our advanced imaging fellowship. I'm going to briefly talk today about artificial intelligence and pediatric cardiac imaging and how that may be an opportunity for us to improve access to care for children in Delaware. So, um, throughout these slides, I want everyone to keep in mind that when we think about access to pediatric cardiology care in 2021, in many ways that equates to access to cardiac ultrasound or echocardiography. So this is a map of Delaware. If anyone doesn't know what Delaware is shaped like, there it is. This is from the American Academy of Pediatrics, and there's a few other groups that have this data publicly available. And this data was made available to demonstrate subspecialty shortages across the country. And if you look at the map, of course, up north we have Wilmington, where driving distances for families to reach a pediatric cardiologist is low, less than 10 miles. If you look to the right, 48% of people live within 10 miles of a pediatric cardiologist. But as you get further south into Delaware, into the more rural areas, you can see that those driving distances really jump. And almost a third of patients or people, children in Delaware, live greater than 40 miles from a pediatric cardiologist. And of course, if you know anything about Delaware, you'll know that public transportation is not as good in southern Delaware as it would be in a more urban environment. So tough to get to care for people down there. This is some of the same information. The idea here is that subspecialty shortages and long driving distances means that people wait much longer for an appointment to see a pediatric cardiologist like myself. For example, in southern Delaware, wait times for my clinic down in Milford, Delaware, is the order of months. And for some of our clinics, it's as long as 6 months. Going without this care or getting care from the right types of providers leaves gaps in treatment and diagnosis. Cardiology is unique in that it is very technologically dense. Of course, we do electrocardiograms, cardiac ultrasounds, or echocardiography, both fetal, transthoracic, and transesophageal. And then there's the more advanced forms of imaging, catheterization, and electrophysiology testing. So not only is geography a limiting factor, but technology is a limiting factor for access. Now, transthoracic echo is the primary tool we use in cardiology for imaging. It's critical for diagnostic purposes and to guide any treatment that we're doing, because we use that, of course, in the hospital setting, in the ICU, in the ER, and then for outpatient visits as well. It's resource intensive. Ultrasound machines are very expensive. Ultrasound probes are very expensive. Tens of thousands of dollars for probes, and ultrasound machines are hundreds of thousands of dollars. For an accredited lab such as ourselves, you need a certified pediatric sonographer, which requires not only training in adult cardiac ultrasound, but additional training and testing and certification in pediatric ultrasound. Then you need a cardiologist to interpret the images that are required, and you have to go through lab accreditation to make all of this come together. So again, access to cardiology, because of how dependent we are on this technology, often equates to access to echocardiography, specifically transthoracic echo. So are there ways that we could reduce barriers to transthoracic echocardiography using point-of-care ultrasound? So I just talked to you about how resource-intensive transthoracic echo is. Are there ways around this that exist today? So yeah, there are less expensive, smaller, portable choices for ultrasound machines. we do actually have less expensive and in a way less fancy probes that will do the job to go along with those portable machines. But how do we get around the certified pediatric sonographer and the cardiologist? We don't really have a way to get around the cardiologist right now, which I guess is good for me. But there are some competing projects going on right now where artificial intelligence is being used and embedded within an ultrasound system to guide an unskilled operator in the acquisition of images. So that's what we're going to focus on. So, how does artificial intelligence guided ultrasound work? So, software is taught or shown what an echo image looks like from our standard views that we use in ultrasound, and also where the sonographer's hand is holding the ultrasound probe to obtain those images. So the system knows what the image should look like and where in space the probe is on someone's chest. So the software is taught that on a large scale amount of data, again, usually tens of thousands of people. Once that software is developed, it's loaded onto one of these cheaper point of care ultrasound machines. And if it works correctly, the software then guides someone with pretty limited ultrasound training to use the system to acquire our gold standard images. So what that could potentially do is reduce the need for specialty training, so you don't have to have this certified pediatric sonographer to get the pictures. And it also reduces staff exposure. In the era of COVID, that's become very important. And if someone on the care team who's not a sonographer or a cardiologist can get the images they need, and pretty much all patients with COVID get a cardiac ultrasound now because of the cardiac effects of COVID, you don't have to expose the cardiology team to get the pictures you need for these patients. So this is one of the products that's out there, kind of the leading product. It's made by a company called Caption Health. This is just for their marketing material. And this is a representation of someone getting a transthoracic ultrasound and the system there on like a podium or post. It's basically the size of an iPad, a bigger iPad. It's a screenshot. So what you're seeing in the center there is the image that's being acquired by the untrained user, and the system is giving you feedback about where you are. So on the top left, there's a bar that goes from white to yellow to green, and when it's green, your image quality is good. On the top, there's directions telling the person where to move their hand, so it's saying slide down the chest. And then on the right, it's showing you a representation of a human torso and where the probe should be oriented. You see at 10, 11, 12, it's telling the person that they should be angled towards 11 o'clock on a clock face. You can see here, there's another image. Once it gets to green, the system actually acquires and stores the image without any input needed. So once the person follows the directions on the screen and the image is in view, it's acquired. The system also automatically determines an ejection fraction from the images without any input. So where is this technology today? It's actually FDA approved for clinical use in anyone over 18. It does not replace a full congenital type of echocardiogram, but it is great for screening purposes and for iterative following of patients. So it's actually being used pretty extensively. Just here in Delaware already, Christiana has 8 of these. They're using them in oncology, in their ER, in the ICU. The Department of Defense is using this to screen. Their goal is to screen all of their current active members of the armed forces with this machine. So it's a huge project to look for evidence of long or chronic COVID on the heart and all their members of the armed forces. So it's been widely adopted in adults. The problem in pediatrics is the testing was never done, um, and the AI system was not trained on pediatric data. So FDA approval for the system just has not been pursued. And part of that is because adult cardiology is big business, pediatric cardiology, frankly, just is not. Um, this is ultrasound, so there's no safety concerns. The probes that are being used on the machine and the ultrasound machine itself are actually FDA approved in children. So what really just needs approval is the artificial intelligence component. And that's where our proposed study comes in. So, in order to know whether the system can be used in children off the shelf, which would be ideal, because development of a new AI algorithm for the software would be a big project. It may need to be done, but we don't know that. So aim one was for us to determine the lower limit of patient size for this ultrasound system. And what we were hypothesizing was that around 25 kilograms of body weight was where the current system, again, just off the shelf, the one that was optimized for adults, that's about, between 50 and 60 pounds, around 60 pounds, would stop generating diagnostic quality images. And that's important to know, basically because we first need to know whether a system optimized for adults in expert hands, we were going to have a sonographer acquire these images and acquire the gold standard images simultaneously. We have to know whether the system can even get diagnostic quality images. If we don't prove that, nothing else is worth doing. So that's aim one. How small of a person can we use this machine for just to get the images we need? So that will inform aim two, where we would actually be using the artificial intelligence tool. This would require FDA off-label approval to do, where we would focus on that weight range of patients where we, in aim one, showed that, say, below 25 kilograms, the system didn't generate good images. So in a narrow weight of patients just above that threshold, we were hoping to try to use the artificial intelligence tool with an untrained user, so as intended, as it's being used in adult cardiology, to see if it would work in pediatrics. And we truly don't know if it will. The artificial intelligence tool was generated on adult data, but there's not that much variability in anatomy. And if the system can generate images, then the artificial intelligence tool should be able to recognize them and guide the user in image acquisition. So together, aim one and aim two would show to what degree the system off the shelf can generate diagnostic quality images in children, and where that threshold is for improvement. So that improvement may mean pediatric specific probes, or a fundamental retraining of the software. We just don't know. But that would spawn, of course, a few more projects down the line. And if it actually requires training of a new AI algorithm, that would be a much bigger project to partner with this group on.